dignitaries for today to please grace the dais. Our principal Rajeev Bagarhatta sir, convener CPC Dr. Puneet Saxena sir, senior professor Department of Medicine, additional principal academics and co-convener CPC Dr. Monica Jain ma'am, and Dr. Sumita Jain ma'am, professor and head Department of Surgery, to please grace the dais. And now I would request Dr. Aradhna Sharma ma'am to please take over for today's CPC.
Thank you, Dr. Shruti. Now heading towards the CPC presentation. Before that, I would like to request respected Principal Sir, Dr. Rajeev Bagarhatta Sir, to say a few words on CPC and PACE. Welcome, sir.
Good afternoon, everybody. Respected seniors, my senior teachers are there. Some of them, they have taught me. My colleagues, my students, members of the Department of Surgery, Head of the Department of Surgery, Dr. Sumita Jain, and of course the team CPC. I welcome you all for this edition of the CLINICO Pathology Conference. As we understand that CPC is probably the pinnacle of academics of any institution. While talking about surgery, my thoughts go back to the giants of surgery department, starting from Dr. S.K. Menon, who was a very well-known surgeon and one of the founder members. He not only founded the Department of Surgery, but much before that, of course, Dr. Jain was the first principal of our college and the surgery department. After that, followed by Dr. S.K. Menon, Dr. Talwar, who was a very erudite surgeon. Not only that he taught surgery, but he was otherwise also a very well-read person. And of course, none other than Dr. G.C. Sharma. From there on, the baton has passed to numerous people, and now I'm so happy that it has come to a very able dignitary, Madam Dr. Sumita Jain. Having said that, the surgery department has progressed from early surgical days in which it was practiced with crude instruments, now to the era of robotics and AI. And I'm so happy that in this year, the robotic department, robotic surgery in the Department of Surgery has really taken off. Thank you for that, Dr. Sumita Jain. But I would also like to add a word of caution here, that whatever artificial intelligence might be practiced, whatever robotic surgery might be practiced, the clinical skills, the bedside skills cannot be replaced. And to hone those skills, CPC is the way to go. And I'm so happy that our team CPC, under the able convenership of Dr. Puneet Saxena and our medical education department with Dr. Monica Jain, it is working really very hard to see the light of the day for this CPC. So I welcome you all for the CPC. You will be in for some surprise at the end of CPC. We'll, come out with that at the end. Thank you. Thank you.
Thanks a lot, sir, for your useful address. Now, I would like to request CPC convener Dr. Puneet Saxena, sir, for SOP presentation.
Good afternoon, everybody. Principal, sir. I can see the very senior people over here, my teachers, Dr. Kasliwal over here, Dr. Mathur, Dr. Garg, and all other senior faculty members and residents and dear students. Dr. Jain and Dr. Sumita Jain, the two Jain ma'ams on this stage. So we have been continuing with the CPC, and this is the fourth CPC which we are holding here. And as Dr. Principal Sir has just said that it's one of the parameters to judge the academics of the institute. So we work very hard to make it a very nice academic event, which is attended by almost all the retired faculties also, and to contribute and share their experiences with us. In that continuation, I just want to reiterate the format that we are doing it on every third Thursday of the month, and the venue is here where we are sitting. And I want to request all those who will be presenting the CPC in the subsequent CPCs that please ensure that the case is a multi-system case which can evoke interest of all the faculties, all the departments rather, and the PG and the UG students. And kindly ensure the attendance also of your department, the residents after making all the necessary arrangements. And in the CPC, the first 10 minutes are dedicated to present the departmental progress, basically whatever new has been added to the department, and followed by the discussion of the case, and then maybe a very small short question and answer session and expert comments from the esteemed faculties and the queries from the residents and the students. So that is the format of presentation. We publish this CPC on the website of the college also. So we'll be archiving all the CPCs, and everybody can see it later on also. Because the cases which we present over here are very rare, and the cases which titillate your mind, so we try to store them also. So with that, I call Dr. Sumita Jain ma'am to present the. So the next CPC would be held on 21st of December also, and it will be done by the Department of Palliative Medicine. So if Dr. Ashwin Mathur is there, please note that. Right. Thank you.
A very good afternoon to all. Happy to see our most senior surgeon, Dr. K.S. Yadav, who is the political leader also, and dignitaries present here, our dynamic principal, Dr. Rajeev Bagarhatta, Dr. A.K. Mathur, Dr. K.M. Garg, Dr. Kasliwala, ex-HOD, and all of you. So a very good afternoon to all. Happy to share that this year I have completed 40 years in the Department of Surgery, and being alumni of this institution, I have seen the growth of this department since last 46 years, which is almost half of the tenure of the total surgical department. At least 75 years is the Department of Surgery, and I have seen it almost 46 years. So Department of Surgery is like a banyan tree. It has given strong pillar to the institution. In 1947, when Lady Wellington Hospital was converted to a teaching hospital, the first great surgeon, Dr. Jain Sen, was made first principal of this prestigious institution, that is SMS Medical College, Jaipur. Not only this pillar was further strengthened by 4 more principals from the department: Dr. S.C. Mehta, Dr. S.K. Menon, Dr. G.C. Sharma, and Dr. Onkar Saxena. To add this, the department had 2 strong political leaders also, Dr. Karan Singh Ji Yadav and Dr. Hari Singh Ji, who had given full support to this institution. At present, we have 18 HODs. Out of this, 17 HODs has given a great leadership to the department, and under their able leadership, the department had grown till date. These are departmental pictures at different phases. At present, we have 8 senior professors as unit head, 4 professors, 13 associate professors, and only 4 assistant professors. Here we lack, and my humble request to the administration that we require at least 10 assistant professors to run the department smoothly. We have 130 residents at present, and the total strength of the department is almost more than 160 now. This department has given many offshoots in the form of stable departments. So basically, this is the mother of all surgical specialty and subspecialty. Orthopedic department was formed under the able guidance of Dr. P.K. Sethi, urology by Dr. Gangwal, neurosurgery by Dr. Sareen, pediatric surgery by Dr. Sogani, CTVS by Dr. G.C. Sharma, plastic surgery by Dr. Chandalia, surgical oncology by Dr. Rajgovind Sharma, surgical gastroenterology by Dr. Ajay and Dr. Ramdaga, HPP by Dr. Dinesh Bharti, and recently trauma by Dr. Dinesh Gora. Department has many upgraded facilities in the department, like surgical JI lab, women oncology clinic at Birla Cancer Center itself, advanced laparoscopic surgery in operation theatre, skill training course at GI lab, and recently inaugurated is the stomach clinic. Our operation theatre is fully loaded with high cost, sophisticated advanced surgery devices like laser, cholecystoscope for hepatobiliary surgery, CIAM for intraoperative X-rays, radiofrequency ablation for varicose vein, frozen section at the time of surgery, intraoperative ultrasonography, hydrodissection for large wound debridement. Our patient load is quite high, that is 2,20,000 patients per year, out of which 25,000 patients gets admitted per year, out of which 75% we get from elective and 25% patients we get from emergency OPD. Allocated beds are 250, including Gangori and Kamatia. Here again, we lack something that in last 10 years, though the number of the admissions have increased to double to triple, and the residents number have increased to double, but the number of beds are quite low. My humble request to the administration to provide us at least 1.5 times to the present capacity. The surgical ICU is still the 9-bedded ICU, but thanks to our dynamic and energetic principal, Dr. Rajeev Bagarhatta, for sanctioning 30-bedded ICU to the surgical department, and hopefully we'll get it within 3 to 4 months. Number of operations done per year is very huge. That is almost 18,000 operations per year, including major, minor, emergency as well as elective, and we are doing almost all advanced surgeries. Out of which mainly we are doing intestinal, hepatobiliary, hernias and breast surgery, and rest every surgery is being done, and our center is almost a high volume center now. In emergency, we have 2 OT and 1 minor OT, and almost 7,500 cases are being done in emergency operation theatre. Again, we require at least 1 more OT because it runs 24/7, and despite that, we have a long waiting list for emergency surgeries to be done. Elective OT has 7 OT table which runs during hospital hours, all 6 days. Each OT has advanced laparoscopic setup. Each unit gets almost 6 to 7 tables per day, except the last Sunday unit. And we do almost 40 to 50 elective surgeries per day. For this, thanks to our anesthetic colleagues, anesthesia colleagues for this getting this milestone. And I am sure that under the able leadership of Dr. Sushil Bhati, we'll achieve many more. Now we have Institute of Traumatology also, that is in the form of trauma center, where though we have 8 OT tables, but there is no dedicated OT for surgery. We do require dedicated OT for surgery, general surgery, for damage control surgery in golden hours. At present, we are getting almost 3,000 general surgery patients, trauma patients per year, and around 850 patients being operated there as damage control surgery. So in Institute of Traumatology, we are doing damage control surgery in the golden hours, as Dr. Dinesh Gora has taken up the trauma part. Now the facilities have been upgraded. So we are doing damage control surgery in the golden hours. We have developed trauma capsule to show how to approach the trauma patient in emergency. ATLS, ACLS and BLS training are still in pipeline. We have learning facilities in the department in the form of e-library, GI lab, where we have laparoscopic endo trainer, and we do conduct interdepartmental panel discussions also. This year, we have started training courses to handle these sophisticated instruments and to do it properly so that it doesn't get misused or mishandled. So we have started cholecystoscope training, laser training, hydrodissector training, robotic training for faculty, for staff, and many more training for staff also to handle the devices properly. Endo trainer training course for students. Department is equally involved in disaster management. I think everyone remembers in 1990-91, department played a pivotal role in management of mass casualties during the riots. In bomb blast of 2008, all casualties were brought in and managed at SMS emergency, primarily by the surgical department. We have almost 700 paper and publication to our credit in national and international journals, and many awards. The highest award was bestowed to Dr. P.K. Sethi. It was Padam Shri Award, though he was shifted to orthopedic department that time. Many other faculty achievement. We have representation as co-author in international research, co-author for national research, peer reviewer for the best journal, World Journal of Surgical Oncology and British Medical Journal, and clinical trials on the breast cancer. Our many residents and faculty got traveling grant also, Dr. G.C. Sharma traveling grant and Dr. Mahesh Verma traveling grant. Proud to say that every year almost 15 to 20 residents get selected in MCH entrance exam, and almost in every super specialty of premier institute, one or other resident of the SMS surgery department is either doing or passed out MCH. And now many more are well-known super specialists at different part of the country and the globe. There are many prominent SMS alumni making a difference in the surgical field worldwide. It's a long list to enumerate. We have a very good academic activity in the department. The best is 4 days classes in the morning, where we get almost 80 to 90% attendance of the resident. We do conduct interdepartmental panel discussions for the residents. We have representation at tumor board at SMS as well as at State Cancer Institute. And we had a great oration by Dr. Badwe in Platinum Jubilee celebration, as well as we participated in the Science of Life exhibition. We conducted many CMEs, workshops, awareness programs, and fellowships program. And we conducted major conferences in 2006, ASICON 2006, then ASICON 2017. And recently we conducted AGES 2023. There we did 3 advanced robotic surgery, 4 advanced laparoscopic surgery, and 3 advanced endoscopic surgery. For the first time, the live robotic surgery was telecasted from the SMS. That made the department the most premier department amongst the medical colleges of India. Apart from this, we have many co-curricular activities, Doctors' Day celebration, Surgeons Premier League, that is cricket extravaganza, and parties at best. And you can appreciate parties. And the best part of the department is now getting the Da Vinci Xi Robo. For that, my heartfelt thanks to our ex-principal and controller, Dr. Sudhir Bhandari, and present principal and controller, Dr. Rajeev Bagarhatta, for providing this most advanced technology. The Robo has 2 parts. One is the Robo, which has 4 arms, and one is the console. I'll be giving just brief, so I'll be taking 5 minutes more. Because of this robotic surgery we have started, we got many laurels to the department, and we remained in media because we did most of the surgeries for the first time in the medical college. So till now we have done almost 128 surgeries, and almost we have done all advanced major general surgeries by Robo. So this is Da Vinci Xi Robo, just to make the aware of this robot surgery to everyone. I'm just taking 2 minutes clipping. I'm just showing 2 minutes clipping. So this is Da Vinci Xi Robo. It has 4 arms. You can appreciate the number is written on the arm, 1, 2, 3, 4. So basically what happens, surgeons has 2 arms. But with Robo, surgeon gets 4 arms. So surgeons is converted into Vishnu avatar. So how it works, I just show you. So you can see this Robo. The ports has been placed on the patient abdomen already. This is a case of achalasia cardia. Once you load that which surgery you are doing, Robo takes its own position. And then we bring the Robo near the patient's abdomen. The ports have been already placed in the abdomen. Robo is coming near the abdomen, over the patient's abdomen. In whichever port we want to put the camera, we bring that arm near that port by checking the laser line cross. You can appreciate it. This laser line cross is coming over the port in which we want to put the camera. And now we'll connect this arm to the port. That is called docking. Once we connect this arm to the port, we put in the camera inside, and we go to that area which is called targeted anatomy. Like in this patient, it is gastroesophageal junction. So we target the anatomy. Once you target the anatomy, robot takes its own position according to the port. Now we are doing targeting. So once you target, the robot takes its own position according to the port. You will appreciate it just now. So now robot has taken its own position. Now we are connecting all other arms to different ports. Once you connect this arm to the port, we pass the instruments, whatever instruments we require, like it may be monopolar Caesar, it may be bipolar grasper, it may be assistant, this thing. So the 4 ports are being connected to different arms. And once you pass the instrument, that is the time when surgeon sits at console and start the surgery. So the instruments are being passed through the port. So now robot is fully docked, loaded with this instrument, and now this is the time when surgeon sits at the console. Now surgeon sits at the console, set up their own ergonomy. So robot, it takes its position according to the surgeon's height and position. And now we start the surgery at console. You can appreciate that even gloves are not required for the surgeon to wear. So it's how comfortable it's. Now you can appreciate the robot is over the patient abdomen. You can appreciate in the screen that the surgery has been started, and you can appreciate the movement of the robotic arms. You can appreciate the movement of robotic arms. The surgery has been started. Next. So now, just a small clip for how we are doing inside. This green cross is targeting the anatomy. You can see 3 instruments inside, and now there's a time when surgeons start the surgery. So here it is the lower esophagus. We are separating lower esophagus from the right crus. This is the case of ecclesia cardia, and we'll be doing cardiomyotomy to relieve the obstruction at the GE junction. Here you can appreciate how bloodless is the field, how magnified is the vision, and because of the endorist, instrument can move in all the directions. Surgeon's arm cannot move in all the directions, but the instruments can move in all the directions. So now the left side of the crus is being separated from the lower esophagus. The whole esophagus is being mobilized to prepare it for the cardiomyotomy. This is the lower 6 to 7 centimeters of the esophagus is being mobilized. You just clear the anterior surface of the esophagus. So you can appreciate, see these fascias which are not actually appreciable in the open surgery or in the even in the laparoscopic surgery. They are quite better, and you can appreciate it in a much better way. So whole of the anterior esophagus is being mobilized for the cardiomyotomy. And now you can see the anterior vagus nerve is being separated, dissected to avoid its injury. This is anterior vagus nerve. It's being separated, and how nicely the bleeding point can be touched with this robotic instruments. So anterior vagus nerve is being separated to prevent its injury. So that's about robotic surgery. I'm not going in detail of it. So apart from having, thank you all. Apart from having advantages of minimal access surgery, that is by laparoscopic surgery, that is magnified vision, no wound-related morbidity, less pain, shorter hospital stay, and better cosmosis, robotic surgery has advantages of high-definition 3D vision, endorist, assistant arm, stable camera, better zoom-in, zoom-out facility, better ergonomic position. So it helps in precise dissection and comfortable suturing. So robotic surgery is the future of all advanced procedures in any surgical specialty. And that's the beginning of new era in the surgery. Our future venture is to start cadaveric skill lab and advanced skill lab, and I'm sure administration will support us for that. So with the slogan that you care for surgeon, we care for you from both inside and outside. Thank you all.
Thanks a lot, ma'am, for departmental presentation and robotic surgery in such a nice manner. Now, I request Dr. Madhulata to start CPC presentation.
Thank you, ma'am. That was really amazing bird's eye view of the milestones of the department, and cherry on top of the cake was the robotic surgery. Thank you. And now I invite, without any delay, Dr. Vinay Srinivas, third-year resident of surgery, to present the case.
Good morning to all the esteemed faculty and my fellow residents present here. My name is Dr. Vinay and I'll be presenting the case for the CPC today. So we begin with the patient details. The patient is a 73-year-old female hailing from the Malpura in Tong district, Rajasthan. And she is a housewife and a farmer by occupation. She presented to us with the chief complaints of swelling of the posterior part of the thigh, of the left thigh since 15 years, restriction of movements at the left knee joint since 1 year, and pain in the swelling since 1 month. Now we come to the history of the present illness. The patient was apparently normal 15 years ago when she noticed the swelling over the posterior aspect of her left thigh, which was insidious in onset and gradually progressive. It was initially of the size 2 × 2 centimeters and now progressed to the current size of 30 × 30 centimeters. The swelling was initially not associated with any pain, but she now complains of pain since 1 month, which was dragging type in nature, not radiating or referred to any site, aggravated on standing and doing any sort of activity, and relieved on rest and medication. The swelling was initially not associated with difficulty in the movements of the joints, but the patient now complains of restriction of the movements at the left knee joint since 1 year. There was no history of ulceration or redness over the swelling, no history of other swellings over the body, or no history of any sudden increase in the size of the swelling, any trauma, significant weight, or appetite loss. There was no history of any bone pain, joint pain, pressure effects like limb swelling, loss of sensations in the limb, or weakness in the movements. So now we come to the past history. There was no history of similar swellings in the body or surgery for any swelling in the past. No history of diabetes, hypertension, tuberculosis, bleeding diathesis, or any other chronic disease. And there was no history of previous surgery or trauma at the same site. There were no history of similar complaints in the family. The patient was a vegetarian by diet, no history of smoking or taking alcohol, and there were no bowel or bladder complaints. She attained menopause 25 years ago and had an obstetric score of P2L1. So now we come to the most important part, which is the physical examination. So this is the patient that we had. She is a 73-year-old female, moderately built and nourished, well-oriented to time, place, and person, being examined in a well-lit room after due consent with adequate exposure from the umbilicus till the mid-calf. The patient was in supine position, lying comfortably in the bed, but when asked to stand, she tended to lean more towards the normal side, which was the right side. On the general physical examination, there was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or any pitting edema. The pulse was 75 beats per minute, normal rate, rhythm, volume, and character. The BP of 108 by 70 millimeters of mercury measured in the right brachial artery, a respiratory rate of 14 per minute, a temperature of 98.6 degrees Fahrenheit, oxygen saturation of 98% on room air, and a Kanofsky performance scale of 60%. So this is the swelling that we'll be talking about today. As you can see, it's a massive swelling present over the entire the posterior region, posterolateral aspect of the left thigh. So the inspection, the patient was examined in the supine, the prone, the left lateral, the right lateral, sitting, and the standing position. There was a solitary ovoid swelling present in the posterior aspect of the left thigh, approximately 35 centimeters by 25 centimeters in size. The surface was smooth with a well-defined margin. The skin over the swelling was stretched out, but there was no redness or edema, ulceration, blackening, nodules, or any visible sinuses over the skin. There were visible veins present over the swelling, as you can appreciate very clearly right here. As you can see, all the visible veins present in this image here. There were no visible pulsations over the swelling or over the surface, and there was no cuff impulse. No distal edema, secondary changes on the skin, or atrophy of the muscle, or any. On palpation, all the inspectory findings were confirmed. A solitary ovoid swelling, which was 33 centimeters in length, 28 centimeters wide, which was measured along the circumference, was present in the posterior and lateral aspect of the left thigh. It was extending 9 centimeters from the ischial tuberosity superiorly till 2 centimeters from the upper part of the popliteal fossa inferiorly. Swelling was non-tender with no local rise in temperature. The margin was well defined. It had a variable consistency, which is an important fact which we will see later on. At places firm and at places it was soft. It was non-fluctuant, non-reducible, non-compressible, and also non-transluminant. Not fixed to the skin and the underlying structures, and was mobile in the transverse direction. There was no change in the size of swelling on movements at hip joint and knee joint, and no loco-regional lymph node enlargement. The swelling was dull to percuss, and there was no audible bruit present over the swelling. Now we come to the perabdominal examination as the remaining part of our physical examination. The abdomen was soft, non-tender across all regions, with no organomegaly, no palpable lumps. The bowel sounds were normal, hernial orifices intact, and the external genitalia were normal. When it comes to CVS and RS, both were normal, with S1, S2 heard with no murmurs, and bilateral normal vesicular breath sounds in both the upper and lower lobes. Now we come to the CNS examination, which I'll be describing only in brief. The patient was conscious, cooperative, and well oriented to time, place, and person, and her higher mental functions were normal. When it comes to the gait, the patient was unable to walk alone due to the weight of the swelling and preferred to place more weight on the right side of the body while walking, and it was a sort of antalgic gait. The motor system, tone and power was normal with no muscle atrophy. And when it comes to the measurements, the left lower limb had a circumference of 90 centimeters at its widest. The sensory system was normal and the reflexes were preserved. So now we'll have the case summary, which is a 73-year-old female hailing from Tong district in Rajasthan. She came to us with chief complaints of a large swelling over the left thigh region since 15 years, associated with pain since 1 month. On examination, there was a solitary swelling of size 33 cos 28 centimeters over the posterior and lateral aspect of the left thigh, which was variable in consistency, non-tender, non-fluctuant, non-compressible, non-reducible, and non-transluminant, with restriction in movements at the left knee joint. There was no local regional lymph node enlargement, and abdominal RS, CVS, and CNS examination was normal. Based on the above findings, we arrived at a differential diagnosis of soft tissue tumor of the thigh. Now I would like to invite my unit head and guide, Dr. Rajendra Bagdi, for the remainder of the presentation.
So in continuation that, I would like to say that we keep the diagnosis according to this examination and history. It is soft tissue tumor of thigh that was benign in nature, and most likely we keep the lipoma with the degenerative changes. So it was the diagnostic dilemma, and it's open for the house. What should be the probable diagnosis? Yes, sir. What else?
AV malformation.
AV, yes. Soft tissue, sir. Yes, sir. Anything else? So we to keep all the diagnosis in this line, that the first is the lipoma, soft tissue tumor, but because of why it was benign, because there was no regional lymph node adenopathy there, and there was no muscle wasting and neurological finding we found in our examination. Then hemangioma was second one, but because of the compressibility and the color change, it was not there. Then the third was lymphangioma, AV malformation, hematoma, and finally the cold abscess. We keep these diagnoses here. Pardon?
Cystic lesion, yes.
Yes. So why we didn't keep this cystic lesion? Because of there was a variable consistency in the history, and there was no fluid thrill or the cystic. It was resonant in nature, so that also comes in the lipoma. That's why. So what points are in favor of our diagnosis are the soft tissue tumor, because it was a well-defined margin with variable consistency and transverse mobility. There was no restricted mobility. So the negative points are that there is no sudden increase in size, no peripheral nerve impairment, no muscle and bone involvement. Why it was not the hemangioma? Because of it was not a common site, but non-fluctuant, non-compressible, no skin changes. In hemangioma, it should be. The lymphangioma, the common site is inguinal or axilla or the head and neck region. And the AV malformation, as madam told, there should be a color change in the swelling also, and it was not there. And hematoma, because the history is long standing since 15 years, and hematoma cannot sustain for this long time, and there is no history of any trauma there. And cold abscess, of course, we can keep it as a cystic swelling, but it cannot be sustained for 15 years. So this was as per our routine investigation, and as per our strategy, we like to go for all routine investigation like hemogram, then the virology, X-ray chest, ECG. Then we send reference to our orthopedic fellow to know the detail about that. Now I'm handing over this mic to the orthopedic fellow, Dr. Hers. Yes.
A gradual progressive well-defined solitary non-tender cystic ovoid swelling of 33 into 28 centimeter size of variable consistency at posterolateral aspect of left thigh was seen, which overlying skin is free and it is also easily movable over bone, suggesting that there is no connection of swelling over the bone, and there is also dragging pain while walking. Range of motion at nearby joint within normal limit, except there is a mechanical hindrance by swelling during flexion of knee joint. Flexion is only of 90 degree at knee joint. Rest range of motion at hip and knee joint are normal. And from our side, we recommended X-ray left thigh full length AP and lateral view along with hip and knee joint and contrast MRI left thigh. Now I would like to call Dr. Swati Bose for neurological opinion.
Good afternoon, everyone. So patient had a large swelling on the posterior aspect of left thigh, approximately 35 into 25 centimeter. She was conscious, cooperative, and well oriented to time, place, and person. Higher mental functions were normal. All cranial examination were normal. In motor system examination, tone was normal, power 5/5 in all muscle groups, DTR were preserved. In sensory system, touch, pain, temperature, proprioception, and vibration were normal. In gait, the patient was having difficulty in walking due to weight of the left thigh swelling and preferred to place over more weight over the right leg while walking. So our DDs of unilateral chronic thigh swellings are nerve sheath tumor like neurofibroma, schwannoma, or perineuroma, but their against points are absence of neurocutaneous markers and absence of neurofibroma elsewhere. Second DD is soft tissue tumor. Third is AV malformation, but there is no apparent venous dilation seen and non-compressible swelling. So we advise MRI of the left thigh from our side. Now our next speaker is radiologist department. I would like to give mic to a radiologist.
Good afternoon to the house. I am Dr. Prama Dubey, Assistant Professor in Radiology, and I'll be talking about the imaging aspect of this patient. So we received a surprise when we received the imaging of this patient. A non-contrast MRI of the affected limb was performed. Good. Just close up. Should I close it? And these were the images. So this is a T1 weighted sagittal view through the left thigh of the patient. And we can see a very large swelling that is multi-loculated
that is high signal intensity on T1 images with multiple smaller cysts that are hypointense on T1 weighted images. When we come to the T2 weighted images, we can see a large cyst with a very well defined hypointense rim with multiple internal hyperintense cysts and multiple floating membranes that we can appreciate here. So these are the floating membranes. I hope these are visible. Again, on fat suppressed imaging, we can again see the floating membranes and the cysts within the larger cyst. So the imaging differentials, first and foremost from our side, would be that of a hydatid cyst, because this was a multiloculated lesion that was hypointense to isointense to hyperintense on T1 weighted imaging, T2 hyperintense. There is a low intensity rim that is usually due to the ectocyst. Multiple daughter cysts were seen, and the water lily sign, that is the floating membranes that were visible, that are highly specific for identification of a hydatid cyst. Other differentials that can be considered include a liposarcoma, specifically the myxoid pleomorphic or dedifferentiated variants. They mostly occur in adults, and the most common location is favored, that is the thigh. These can appear cystic on non-enhanced imaging, but on application of contrast, they show heterogeneous enhancement. These are aggressive tumors that have a propensity to metastasize early. Another differential that can be considered is that of an undifferentiated pleomorphic sarcoma, or UPS. This is the most common soft tissue sarcoma, and the most common site of such a sarcoma is the thigh. That is the lower extremities. These appear as relatively well circumscribed masses. These two are aggressive, they metastasize early, but the appearance is more heterogeneous because of the frequent occurrence of mineralization, of necrosis, of hemorrhage within them. They enhance heterogeneously again when contrast is given. Another DD that can be considered is that of a lymphatic malformation of the macrocystic variety. So where the cysts are more than 1 centimeter in size, these two appear as multiloculated cystic masses. They show multi-compartmentality that was visible in this case. So here the mass is seen in the posterior compartment of the thigh, and it is predominantly in the intra and intermuscular compartment, but it is seen to extend in the subcutaneous plane as well. So this is multi-compartmentality. So a differential of lymphangioma can be considered. But lymphangioma is present earlier on in life, that is more than 90% present before the age of 2 years. Our primary DD would be that of a hydatid cyst, because these are the references, membranes or the serpent sign that can be seen within a hydatid cyst due to detachment of the daughter cysts are highly specific for diagnosis of hydatid cysts. I now hand over the podium to Dr. Vidushi for the pathologist's puzzle.
Good afternoon, everyone. Now the pathologist's puzzle, whether to conduct a FNA or true cut biopsy in this case. So we will not suggest an FNA or true cut biopsy in this patient, since one of the imaging differentials is hydatid cyst, which is a clear contraindication to the procedure because it can lead to severe catastrophic anaphylactic reactions. So no FNAC for this patient. Dr. Akanksha from microbiology, please. So a 73-year-old farmer who's living in a rural area and closely working with animals gives us an idea of a zoonotic infection, which is possibly transmitted via fecal-oral route. For this, a wet mount examination of the cyst fluid, which has hooklets and hydatid sand, will confirm the echinococcus, echinococcus. Serodiagnosis, which should be used with conjunction with the imaging studies, as previously shown. We can do antibody estimation for them via ELISA,
IHA, latex agglutination test, Western blot, as well as antigen testing for countercurrent immunoelectrophoresis and ELISA. However, these have very variable sensitivity and specificity, so we do not use them to confirm the diagnosis, just to support it. Cassoni's test is of historical importance. It is no longer being done. So hydatid disease is a parasitic disease which is endemic to the Mediterranean and Southern American countries. However, it is also frequently observed all over the world because of increase in global travel. Now, it is a zoonotic infection caused by Echinococcus species, which is spread by carnivores as well as pets, with man acting as the accidental intermediate host. The hydatid cyst can be ubiquitous, but commonly affects the liver as it is the first filter, followed by lungs and less frequently the kidneys, spleen, muscles, and CNS. Echinococcosis is recognized as a global public health problem which has been found in all sheep raising countries, including India. Annual incidences are 1 to 200 per 1 lakh population, with the highest prevalence in Andhra Pradesh and Tamil Nadu. The perpetuation of echinococcosis depends upon the common presence of the parasite, the definitive and intermediate host. The continued existence of parasitic populations in host depends upon the fine balance of various interacting regulatory forces like environmental chain and host immunity. The patient is normally asymptomatic for an incubation period that lasts over many years, even decades. The most common clinical symptoms are usually due to pressure symptoms of the cyst and the hypersensitivity reactions related to it. So for a liver hydatid, it would present normally as an abdominal pain, nausea, or vomiting. In case of an intrabiliary rupture, it can range from asymptomatic to jaundice, cholecystitis, cholangitis, liver abscess, and septicemia. If the lung is infected, clinical signs include chronic cough, chest pain, and shortness of breath. Non-specific signs like anorexia, weight loss, and weakness can also be seen. Coming to life cycle, so Echinococcus granulosus sensu lato, formerly known as Echinococcus granulosus, is the causative agent for cystic echinococcosis. Now, it is a tissue cestode, which is also known as a dog tapeworm, and it is present in the intestine of dogs as an adult worm, which matures and releases the eggs in its feces that contaminate the nearby soil, water, or food particles. Which is ingested by the intermediate host, that is the sheep. Inside the sheep, the egg hatches, it penetrates the intestine, enters the circulation, and reaches various tissue sites, where it presents as a hydatid cyst. This hydatid cyst is then eaten by the dogs when they are given access to the sheep viscera, and they develop inside them as protoscolex, scolex, and adult worm. Hence, the cycle is perpetuated. Humans become the accidental host when they consume the contaminated food or water, which is contaminated with dog feces that have the infected ova. And thereby they present with hydatid cysts, most commonly in the liver as it is the first filter, but it can be anywhere in the body. Prevention aims at raising awareness through public health education campaigns, especially in pet owners and farmers who are in close contact with animals. Control occurs at 3 levels. That is a definitive host level, where we do periodic deworming of dogs with praziquantel. At the intermediate host, which is the sheep, we can go for improvement in hygiene of livestock in slaughterhouses, as well as safe disposal and destruction of infected viscera so that dogs do not have access to this viscera. In Argentina and China, a recombinant vaccine, EG95, is being used to vaccinate the lambs before first year of life, so that which has led to the reduction in the prevalence of the cysts and the disease. As accidental hosts, our only mode of control is to have personal hygiene so that we do not accidentally consume contaminated food that is with dog feces that have the eggs. I now hand over to Dr. Reshma from anesthesia.
Respected faculties and dear residents, I am here to present the anesthetic management of this case. Preoperative evaluation of this case was done 1 day prior to surgery. All routine investigations and systemic examination were within normal limits. Spine examination was found to be normal. Informed high-risk consent was taken in view of anaphylaxis due to spillage of contents of cyst during surgery and postoperative ICU requirement. Patient was taken in OT. NBM status was confirmed. 2 IV cannula were secured in both hands and IV fluid was started. Monitor was attached and baseline parameters were recorded. Emergency drugs and emergency airway cart was kept ready as there is a chance of anaphylaxis. Injection adrenaline, injection hydrocortisone, injection dexamethasone, injection phenyramine maleate, injection atropine, injection noradrenaline, injection dopamine, injection dobutamine, injection methylprednisolone, defibrillator, crystalloids and colloids were kept ready. With full aseptic precautions, spinal anesthesia was administered with 25 gauge spinal needle and 3 ml of 0.5% heavy bupivacaine was injected intrathecally in L3, L4 space in sitting position while patient was on trolley. After waiting for 10 minutes for the drug to get fixed, level of spinal blockade was checked and patient was shifted to OT table in prone position, supported on chest and pelvic bolsters with abdomen free. Care was taken to ensure proper padding of eyes and other pressure points to prevent pressure sores or skin necrosis. Care was taken to support both arms to avoid over abduction to prevent undue stretching or compression of nerves. Injection hydrocortisone 100 mg IV and injection phenyramine maleate 1 ampule IV given prophylactically. Vital parameters were monitored every 2 minutes for the first 15 minutes and then every 5 minutes till the end of surgery. Oxygen was supplemented with face mask at 4 liters per minute. Vigilance was kept for sudden and persistent desaturation, severe hypotension, bradycardia, flushing and erythema in view of anaphylaxis. Adequate hydration and input-output charting was done. Injection paracetamol 1 gram IV infusion was given towards the end of surgery for postoperative analgesia. Patient was shifted to recovery with stable vitals after the completion of surgery. Thank you. Now I would like to inform Dr. Rajendra Bagri sir for further discussion.
So, as I didn't answer at one place, as Dr. Asim says that there may be the neurofibroma or the nerve sheath tumor. So, here was we differentiate this. The patient was not having any neurological deficiency and there was no wasting of muscle. So, this diagnosis was eliminated here. So here, after going through all the due references, we decide this patient to take for operation. Why we wander all around, we keep this radiological finding last because in this case, only heart was from the radiology site. There was the only place where every diagnosis was hidden and no FNAC or true cut was done because of the fear of this anaphylactic reaction. Patient was taken in OT. As we know, there are different modalities of doing these surgeries. So we plan that the pair, the puncture, aspiration, injection, and aspiration. Then scolicidal agents like hypertonic saline, 90%, 95% alcohol, 3% hydrogen peroxide, and povidone iodine solution as 5%. So the surgical management was we planned because there was a big cyst and it was thick walled, and due to thick wall there was no transillumination positive in this case. So we can do organ specific that the laparoscopic pair with the tube drainage, then the open pair, the total cystectomy, partial cystectomy, omentoplasty, then the organ specific management like nephrectomy, splenectomy, partial nephrectomy, then the residual surgery like pericystectomy and hepatectomy. So per operative finding in this case was very typical that we took the patient in the prone position as mentioned by the anesthetic people. After going through the proper painting and draping, we put a needle first to decompress the cyst pressure. And we was very sure with the only one diagnosis, that is MRI. And I think they must have done the real-time USG also. But the diagnosis was not hidden anywhere else than the radiologist. So we think the cystic swelling size approximately 13 to 30 centimeter was present over the posterior aspect of the thigh, containing approximately 5 liters of yellowish thick fluid and multiple small pearl white cysts in that. The cyst was present in the intramuscular and subcutaneous plane. The operative procedure was conducted after the due consent with explained risk of her condition. The procedure was and complication of this procedure. Patient was taken under spinal anesthesia, and the gauze soaked in Savlon solution are placed around the swelling under all aseptic precaution. 50 cc syringe was taken and 16 gauge needle we use and insert in the swelling, aspirate approximately 150 in 3 or 4 attempts, and was done, and same amount of chlorhexidine 1.5% Savlon was injected into the swelling. And looking to the fluid aspiration and MRI finding, our diagnosis was doubly confirmed here. And this was the open site of cyst, and there is a thick wall cyst. It was a small video during surgery because there was nothing else than the thick fluid, and the yellow coloration was due to our chlorhexidine solution. We taken out is as whole. After completion of this procedure, this is our cystic wall. We removed it in total, and after completion this surgery, it was around 20 centimeter long incision at the posterior aspect of thigh, and we put 2 drain for the any aspiration content in the wound site. The postoperative period, patient was kept in our ward postoperative till 4 days. Observation and further workup was made for the hydrated cyst at the other places. She was started the suitable antibiotic which was available with us. She was switched to the oral antibiotic on the next day, and patient was referred to physician for further management for the zoonotic, and drain was removed on the day 4. So here, after how long and how to give the anti-zoonotic medicines, I am handing over to the physician.
Thank you, sir. Now we discuss about the medical management of the hydratic cyst. Hydratic cyst management is depends on the number, size, and location of the cyst. So WHO guidelines are recommended for this. According to this, there is a stages for 1 to 5, and in this, as seen in the table, there is first 2 stages are active stage, and last 2 are the inactive stage. Sorry. So as shown in this slide, this is the guideline which is proposed by the WHO. This is a Garfield guideline. According to this, there is the first 2 are the active cysts are there in this, and in between that 3A and B shows the transitional phase, and 4 and 5 is the inactive phase. So for the further management, these guidelines are essential. So before starting the medical management, we should look for the indication when there is a single uncomplicated cyst which is size of less 4 centimeter, surgically unfit patients, recurrent cyst, widely disseminated hydratic cyst disease, and localized disease with poor surgical risk, rupture risk, and the intraoperative spillage are the indication for the medical management. So before starting the medical management, we have seen the slide is showing the what stage is there, and according to that we can start the treatment. Whether it is require the only medical management is essential, or along with the medical management, the surgical is also needed. So in stage 1 and 3, they are according to WHO, in which there is single cell is there is and diameter is less than 5 centimeter, only drug treatment is sufficient. But in cases of when the size is more than 5 centimeter, along with the stage of 2 and 3B, multiple compartment is there, in which along with the drug treatment, pair or the surgical resection is needed. But in cases of 4 and 5 stage, in which the cyst is inactive, drug treatment is not necessary. But if there is the only cyst, deep cyst is present, and along with there is a percutaneous and peritoneal cyst is there, medical management is required. So these are the modalities in cases of the hydratic cyst treatment. For the adjuvant therapy, it is most important in cases of the hydratic cyst management to prevent or to minimize the risk of secondary echinosis. There are two types of categories of drugs are used in this. One is the benzimidazole and second is the isoquinones. So benzimidazole are the albendazole and mebendazole. Albendazole is used in doses of 10 to 15 mg per kg body weight. Highest dose is the 400 mg BD. It is given in twice along with the meal. So their fast absorption is there. And next is the mebendazole, 40 to 50 mg per kg body weight. And these drugs are act on the microtubules and finally a subsequent mechanism of reaction and lead to the hamper the germination of the membrane and death of the cyst. So these are the mechanism. And next is the prazoquintal, which is the isoquinol drug and which act as a on the cell membrane, which increase the permeability of the cell, which leads to the extracellular shift of the calcium and paralysis of the cyst. And it is given in dose of 40 mg per kg body weight in two divided doses. But if it is given in the along with the prazoquintal along with the albendazole, it is more active for the killing of this cyst. But documents available are not sufficient for this treatment. The duration of therapy is usually 4 days prior to the surgery and at least 1 month with the albendazole after surgery and 3 months after the mebendazole. But WHO also recommend that 4 to 30 days pre-operative management can be recommended. There are some contraindication for the start of this medical therapy, like pregnancy, bone marrow suppression, chronic hepatic disease, and inactive or calcified cyst. Death of the protocidals can be increased by the use of the prazoquintal 50 mg per kg body weight for 2 weeks or bi-weekly throughout the duration along with the albendazole. But as I said, these documents are not available in support of this. So we usually use single drug albendazole. And some documents in around 1,000 cystic lesions patients are treated with the albendazole for duration of the 12 to 6 months. And result found that 30% cases are cured. That means that there is no cyst in the no cyst is present in the cavity. And next is the 50% they have seen the improvement, that is decrease in the size of the cyst. And there is no changes found in 20% cases. So this albendazole therapy is the most prevalent therapy in this case. But as I talked to you, that it is because this is treatment is for the cystic echinococcus. But in cases of alveolar, the duration of therapy is long. It might be 2 years or more may be needed. So this is the all about the medical management of the hydatid cyst. Now I call to pathologist Dr. Vidushi for further discussion.
In the pathology department, the specimen was received in 2 containers separately labeled as A, cyst wall, and B, cyst contents. On gross examination, the tissues were of variable sized, flap-like structures, gray-white to white in color. These were processed, slide stained with hematoxylin and eosin, and the histopathology findings are as follows. Sections from the excised cyst wall showed fibrocollagenous tissue with dense mixed inflammatory cell infiltrate, foreign body giant cell reaction, and necrotic foci. This is a scanner view of this is the image of the scanner view, which shows the outer fibrous cyst wall. On the higher magnification of the same image, we can see the chronic inflammatory cell infiltrate comprising of lymphocytes, plasma cells, histiocytes, foreign body kind of giant cell reaction. Foci of necrosis can also be appreciated. Sections taken from the contents of the cyst revealed an acellular laminated layer of uniform thickness, with the innermost layer being lined by 1 cell-thick germinal layer. No protoscolices or hooklets were seen. This is the acellular laminated layer. And on the higher magnification, we can see the innermost germinal layer. Now, these findings are quite characteristic of the echinococcal cyst. So the impression, cystic echinococcosis or hydatid cyst. I request Bagri sir to take over.
So, presentation of this case here is not the disease, but only reason is the site. Because at the time of admission, we thought that after taking one biopsy or core biopsy, after confirmation of histological confirmation, we will send the patient to the respective department. As soon as we admit the patient, we sent the patient for the MRI, and the diagnosis was magical. And we was not able to understand for a long time, but we meet to the radiologist, we ask again, then they did the real-time USG and they confirm it doubly that it is hydrated cyst. So no other further investigation was done. As this literature is mentioned that it is 18th, I think 17 he has reported, and this case is 18th globally. So according to the surgical profile, as I'm a general surgeon, I'm dealing with abdomen. I've gone through the many organ-specific sites like liver, then the kidney, then lungs, spleen, and inguinal canal and CBD. And this was a very specific, unique site for me. So take-home message is that any swelling anywhere in body may give a radiological or pathological surprise, and in that scenario, hydrated should keep always be in mind. So, as per our surgery ethics, we like to say that any doctor says relax, a little swelling is maybe normal. Don't worry. So again, I would like to give my big thanks to Principal Sir and ADP Academics, Dr. Puneet Saxena, and special thanks to PHOD Dr. Sumita Jain, who has given this opportunity me to present this case. Thank you.
Thank you, sir, and thank you to the entire surgery department for this amazing CPC.